things reflexly, and that contributes to diagnostic errors. Once the diagnosis is incorrect, then it erodes the trust. It jeopardizes the outcome of the patient. It causes extra burden on the cost. Medical errors, sir, are responsible for an additional cost on healthcare of $50 billion per year. So this is all preventable if we start with the right history, spend time with the patient, and if we have systems in place. Unfortunately, when we are overburdened with patients, we do not have systems. So first is the cognitive problem, that the physician herself or himself is at fault. Then are the systems. अब वो हमें कहते हैं कि जी EMR, इलेक्ट्रॉनिक मेडिकल रिकॉर्ड होना चाहिए. आप बड़े-बड़े ओहदों पर रहे हैं माशाल्लाह, and you have headed so many institutions, and now you are at the helm of the policy making in the province of Sindh, and with the status of a minister. So you should know that these doctors, EMR requires time. If you go to US and UK, a doctor is supposed to see only a maximum number of 10 to 12 patients in one day, because it takes 30 minutes to register the patient on EMR. तो एक तरफ expectation है कि EMR हो, दूसरी तरफ number of patients ज़्यादा है. फिर हम जब मांगते हैं as a physician sir, we ask for a data entry operator, तो वो कहते हैं नहीं, ये आपने खुद करना है. तो बड़ी ही एक dilemma है. फिर दो चीजें और हैं, with the permission of the chair, I would like to highlight जो diagnostic error में significantly contribute करती है. एक है health disparities, और आपसे ज़्यादा कौन aware होगा कि जब मरीज आता है हॉस्पिटल में, तो वो लोग जिनको सबसे ज्यादा जरूरत होती है केयर की, they end up receiving the least care. I will highlight few examples. People who inject drugs, doctors, most of them look down upon them. ऐसे जैसे वो कोई जुर्म करके आ रहा है, वो तो बेचारा ड्रग एडिक्ट अपनी मर्जी से नहीं हुआ है, वो तो आपकी शफकत और मोहब्बत चाह रहा है. People who are left unattended, people who are poor and marginalized, people who are mentally challenged, people who are old and who have multi-morbidity, ये सारों को ज्यादा जरूरत है, और प्रिजनर्स, लेकिन इनको कम मिलता है. तो एक ये भी वजह है डायग्नोस्टिक एरर्स की और मेडिकल एरर की. और सर एक और वजह वो है ये सिस्टम कोई इंसेंटिवाइज नहीं करता. या कोई अच्छा काम कर रहा है या बुरा काम कर रहा है, वो सबके लिए बराबर है.
Dr. Naveed, continuing with what Aftab sir ने बताया in a very, very nice, elaborative way, what errors are. Don't you think, as he has said, that right now we are emphasizing more on the diagnostic tools rather than applying our knowledge of medicine in the form of history taking, examination, which our professors used to emphasize a lot. And they were of the view that, as he has very correctly said, that majority of the diagnoses are made on that. Today, हमारे साथ जो लोग हैं, because of the availability of CT scan, MRI, so many things, the first thing we do is when the patient comes, we say, boy, it's about a headache, MRI करा क्या? Now taking an easy way out to diagnose, because we have got so much rush, we don't want to examine him properly for that. आप क्या समझते हैं, does it contributing to diagnostic error, and how can it be overcome?
Sir, thank you very much for giving me a chance to elaborate myself on such an important topic. So you are very right, sir. Said a very important sentence in the beginning that listen to the patient, he is telling you the diagnosis. So I personally feel that one factor is the patient's workload, because a doctor has to see a lot of patients in 3 to 4 hours, and the patient expects that the doctor should not only listen to him or her, he should also examine her and him and then prescribe the relevant investigation. But I personally feel, sir, keeping in view all these limitations, they are there, but one link is definitely missing, and that is we do not touch our patient. That sense of touch, like we talk of the sense of touch between the mom and the baby. Exactly the same relation exists between the patient and the doctor. This link is missing. And how we can re-establish this link, I don't know, because the patient to doctor number is too much. But I personally believe that this factor should be addressed seriously, and this should not only develop the patient-doctor, strengthen the patient-doctor relation, but it also decrease the workload on our investigations. Like, number one, the patient expects a doctor sahab ko test nahi likha, so doctor writes the whole battery of the investigation, including chemistry and radiology and everything. But if we start doing that, and if we start developing the rapport with the patient in terms of detailed history and clinical examination, and then full explanation to the patient, because once the patient leaves the office of the clinician, he's I don't know, मुझे तो नहीं पता डॉक्टर साहब ने कि मुझे क्या मसला है. So we should properly explain the patient, and it would definitely decrease the workload on our investigation to better investigation. As sir mentioned, I was reading a few days back, because it would also jeopardize the number of patients. It would also jeopardize the patient safety as well, which is our prime topic today. And recently I was reading an article in which it was mentioned that the number of deaths in USA, because USA and UK, they are the icons for us. We read the books written by their doctors, and it counts around 2 lakh a year because of the breach in the patient safety chain. And number two example of UK, the NHS budget rose almost to 40% in the last 1 to 2 years. So I personally believe, sir, highlighting the very true topic of this age, the number of patients is the main cause that our diagnostic battery of investigation rate is rising, and we are missing the link between the patient and doctor, because we cannot explain to him, we cannot examine to him.
Samad sahab, ये बताएं कि because you are in digital, which is the latest thing like AI and other things the companies, do you have any solution for the problem that has been raised for overcoming these diagnostic errors? Do you have that? Not only relying upon the diagnostic tool, because once the tool goes wrong, the whole management will go wrong. So, do you think that the recent trends that you were just talking about, bringing up together, can they be of any support in overcoming this decision making of a diagnostic tool not to go wrong?
Assalamu alaikum. Thank you so much, sir. First of all, we at Digitrends currently working on the AI solutions which we think can make a difference in patient safety. I will give you for example which I think is relevant, how AI and IT can make a big impact on patient safety. First of all, we are going to integrate it with our EMR solution. So currently in the conventional EMR, if doctor enter the wrong medicine, or if any medicine which is not suitable for the patient, he has the allergies or some kind of histories, doctor cannot go through all the EMR details every time, and he can enter wrongly some medicine which may affect the health of the patient. Our AI system can be integrated with the EMR, and it can, in the real time, stop the doctor that do not enter that kind of medication that can be harmful for the patient. This is the one example, and there are many other features which can be very helpful when AI will be integrated into the current AMR solution. The second example would be, we are currently working on the world first FDA-approved wearable ECG device. So currently what is happening, when the device is taking the ECG of the patient, it is transmitting the data to the mobile application, and that mobile application submitting that data to the doctor, who is actually manually reading the ECG, and then he is diagnosing and prescribing the medication over his whatever he sees over his diagnosis. Now, if we integrate AI into that in between, where doctor is currently diagnosing or checking the ECG, the AI system can do this automatically, and he can suggest, the AI can suggest either the patient needs immediate attention of the doctor, so it can send the ambulance, or through through telemedicine, doctor can connect to the patient directly. So if we will integrate AI agents into this healthcare hardware monitoring system with the patient and doctor, that AI can do the job of the doctor, the initial job of the doctor. So it can be make great impact as well. The third thing is that differential diagnosis tool. We are partnered with the leading differential diagnosis tools such as Visual DX. So we integrated that Visual diagnosis. We launched that differential diagnosis tool here in Pakistan. And we saw a very good adaptation on AI on that tool. If you take a picture of your skin region, the AI image recognition system can recognize either it's psoriasis or eczema through the thousands of images which is already stored in the database of the AI. And doctor who maybe he cannot diagnose that this is the early stage of psoriasis, AI can detect it in a very early stage. So these are the 3-4 examples which I think, and this is already happening in the world. AI has been integrated. The question is, we are not only trying to implement and integrate these solutions currently within this Pakistan market and in Saudi and in Dubai. We are also taking care how the AI governance and how AI compliances can be a part of it. So it can be implemented. Again, it's related to patient safety also. So I think AI will make a great impact, inshallah.
Thank you. Dr. Mema, my question to you, because you're also associated with the pharmaceutical, what prescribing safeguards are there for effective avoiding any prescribing liquidity or anything that can be a wrong prescription because you're associated with the pharmaceutical? What safeguard the pharmaceutical has done to them? For example, I can give you a number of medicines with a similar name, similar appearance. In cases of emergency, sometimes the nurse picks up the wrong one, and it may be illegal for the patient. So, what are the safeguards that the pharmaceuticals taking in order to avoid these prescribing?
All right. Thank you so much. My name is Umema. Thank you for inviting. I'm representing a pharmaceutical company here, but I also hold a position for a primary healthcare setup here in Karachi. So I have kind of an ambit or a cap of both, say it from a pharmaceutical perspective and from the hospital end as well. And there have been a lot of solutions that आपने AI की बात करी, and there are a lot of integrations. And same goes when it comes to patient safety, and we talk about what systems can be implemented in pharmaceutical companies. But before I can actually talk about what should be done, I'll be talking about a patient safety culture. And there is a small presentation, if you may all allow me to give a small presentation of the magnitude of patient safety which we are talking about, especially here in Pakistan. So, sir, if you may allow, I'll just give a brief presentation. It's hardly of 10, 11 slides.
Time, so we can just discuss that now. You can give us a brief description about that.
I'm sorry?
We are running short of time, so...
Okay. All right. So I'll just make it very precise. See, for me, when it comes to ADR or pharmacovigilance, or we talk about reporting system, the first thing which has to come is to start reporting. We do not hold here a culture of reporting. DRAP already has established systems in which the healthcare providers and the people who are in the pharmaceutical companies are encouraged to report any ADR which is reported. And I'm talking about the drug reporting errors. I'm not talking about the medical errors, jaise Dr. Saab ne initially kaha ki that also comes under the ambit of medical error. But unless and until we do not know what is being reported and what are the root causes of it, how are we going to actually establish systems in our areas to counter that? And I'm sorry, I was not able to listen to your specific questions regarding pharmacovigilance.
Regarding the drug use, for example, recently, DRAP has withdrawn a syrup because it was causing a lot of complications. Many medicines are withdrawn. So, what pharmaceutical industry is taking care of avoiding those errors to take place when you are manufacturing a medicine? What are the protocols that you follow? Are there any protocols?
Yes, definitely. See, pharmaceutical companies, especially in Pakistan, I would consider this is the most regulated industry in Pakistan, and it has federal regulations applying to it as well as the provincial ones. So there are systems established. Say, for example, I'd give an example of LASA, which is called as the lookalike enzyme rely, which is the major one of the major causes of wrong administration or wrong prescribing. And there is a whole system established by pharmaceutical companies, especially the MNCs as well as the local pharmaceutical companies. They have established systems in which they do have protocols, and especially with the integration of AI into such systems, we are able to check that. And similarly goes with the names. But unfortunately, I would refer to the recent cases of Avastin, as we all are well aware, the case of ceftriaxone, we already know that. But these were malpractices of administration rather than something which was falling under the pharmaceutical category. So the indications are, of course, devised.
Thank you very much. Nashwa, you are related to a hospital, a major hospital in the city. So what do you think in a hospital? We all know there are so many cases reported, so many errors take place. We wait time to the patient. Patients have lost life. So do you think, what are the major protocols that could be applied, or what are the systems that need to be in place in order to avoid all that what is unfortunately happening if patients are being mistreated or being misdiagnosed or whatever you say, which is harmful to the patient whenever they come to the hospital? Any protocols, systems that you think are there, or you will suggest them to be applied?
Ji, Assalamualaikum. Thank you, sir, for having us. Thank you for having us. So I work very closely with a lot of workflows with different kinds of healthcare providers, be them physicians or nurses. Now, in terms of reducing harm, there are different components to how you can reduce harm based on who the provider is. जैसे हमने आज की discussion में देखा है, the physician's perspective or the surgeon's perspective is very unique and different. They have different goals for the patient, be it their assessment, their diagnostics, the treatment plan. That is a vision which is dedicated to the physician. Where safety falls in, where measures fall in, where systems fall in to reduce harm in that pathway is separate. That is something that is addressed separately, that has different patterns, different safety measures. If we're talking about surgery, for example, something which may seem like a very simple process, but starting from when the moment the patient arrives in your clinic, what is being communicated, what is being documented, what is going on the record, what does the patient understand from everything the surgeon is saying? And in the event of a harm happening, was that harm pre-warned, pre-informed to the patient? Was it uninformed to the patient? What are accountability measures in place for the surgeon or for the providers? So, surgeons, for example, nursing is a completely different game. Nursing ka role is absolutely separate. They are more involved with the hands-on care of the patient in a time which is vaster than it is for the physician. How to reduce patient falls, how to prevent the patient from getting harmed from regular activities while they're in the hospital setting, during mobilization, during eating, to prevent aspiration, for example, to prevent medication errors. What is the process of the medication cycle? Uske humne kaun se metrics, accountability tools rakhe to make sure medication is being given safely.
Also, being a physician, there are a number of times we are prescribing a medicine. A patient has got a problem. He says, for example, full factor deficiency, I have got epilepsy. And when we are prescribing a medicine for that, not for that, for other reasons, we at times do not know whether this medicine will be harmful to that or is contraindicated to that. So at times we miss, because no doctor can have knowledge about every disease and what medicines can indicate. Do you think the use of e-prescription could be effective in that, or still the use of our own intelligence in that will be more effective?
I think, sir, you have rightly pointed out, electronic medical record or e-prescription can help reduce it, magar it cannot eliminate it. Healthcare industry is supposed to be an industry which is far less regulated than many other industries like flying industry. People who are flying jets and airlines, they are far more meticulous in their approach, whereas the number of people suffering at the hands of medical error is far more. In USA alone, medical errors have become the third leading cause of death. Of them, there are 250,000 every year. Half of them are preventable. And sir, 250,000 makes it about 680 per day. That is like 1.5 jumbo jet going down every day. And look at the time, look at the method, look at the money that is being spent on airline safety compared to healthcare safety in our profession. So something we are doing is absolutely wrong, and it requires a paradigm shift.
So what do you suggest? Like, as we have very correctly said, there are a number of prescribing errors that we are making. Even the most senior ones make an error in prescription, and they miss on the history of the patient because EMR is very good, it's a new thing. But practically speaking, as we have been working in the government sector hospital, the prescription when you write the government sector hospital and an OPD with 300 patients standing and you have to pass within 3 to 4 hours, it's not possible to go for an EMR for each one of them. Either it should be a limited number of patients that you are seeing, but you are seeing an uncounted number of patients. उस कंडीशन के अंदर what do you suggest, what protocol or what safety measures could be undertaken कि आप either it should be at the end of the prescribing doctor or the pharmacy which is issuing should take care of that when the pharmaceutical after prescription जाए that this drug should not be given to this patient or the dosage is not correct. What do you think? How could it be counteracted?
I think, sir, you have highlighted the issue in your own question that it cannot be anyone working in isolation. What we are doing right now is working in silos. Physician working as a physician, pharmacist working there. EMR, I don't think is going to be the solution in Pakistan. There are two things. I am an old school. I believe that if you spend quality time with the patient, that not only builds trust, it also ensures patient safety and it also ensures quality care to the patient. But at the same time, we have to think differently. The money cannot go to the armed forces of Pakistan and our patients deprived of their due rights. ये कहाँ पर होता है कि 1% GDP से भी कम हम एजुकेशन और 1% से कम हेल्थ पे खर्च कर रहे हैं. This thing will have to change if you want to change or contribute. अमेरिका में वो कहते हैं कि हम 2,50,000 लोग हमारे मरते हैं हर साल और वो कहते हैं कि 3 मिलियन लोग मरते हैं दुनिया में हर साल. पाकिस्तान में तो रिपोर्ट ही नहीं होती. India में 54 million medical errors take place every year, which is among us. So हमारे तो वो figures ही नहीं है. So we have to bring in more money, we have to bring in more resources. और वो पाकिस्तान के कहाँ से आएंगे? डेट सर्विसिंग से आएंगे, आर्म फोर्सेस से लेंगे. ये अभी बात हो रही थी सर कि प्राइमरी हेल्थ केयर पे पैसा नहीं लगाते और इंडस को 10 बिलियन दे दिया. भाई इंडस को 10 नहीं 20 चाहिए, मगर ये नहीं है कि वो ये समझते हैं कि इंडस से लेके नहीं लगाया जा सकता. इंडस को पहले ही ज्यादा चाहिए, आपको मजीद पैसा चाहिए और उसको लाना पड़ेगा in order to improve the health. Or EMR is not the solution, sir.
So what we conclude is that though these gadgets are very good, the EMR or the digitalization, जैसे आपने कहा, But it is not this case. You can have a blanket thing from the US coming to Pakistan and make it take. We have to cut it according to our own needs and our own requirements and our own problems that we have. सबसे बड़ा इशू ये कि you don't have that much of resources available. जैसे कि रोबोटिक के वक्त सिंध में एक बड़ा हंगामा हुआ whether to buy a robot or not to buy a robot, costing billions of rupees. Whether that should be spent on a robot to be bought or that should be spent on primary health care. Because tertiary health care should be is given more emphasis upon in every part of Pakistan rather than the primary health care. जबकि दुनिया भर में मैं समझता प्राइमरी हेल्थ केयर ज़्यादा करते हैं ताकि आपको पेशेंट ही ना है, क्लीन वाटर नहीं है आपके पास, सिविलाइजेशन की कमी है, दे ऑल बेटर. मैं नवीद साहब आपसे पूछूंगा, being a surgeon, sir, we make a lot of errors. I am a surgeon myself. Sir, what checklist, team communication strategies, or data tools you will suggest that can avoid those errors that we make during our surgery?
Sir, so this is a very important topic, and I think this is all we being clinicians are meant for. The patient safety first. And these all checklists, they are meant for this purpose. There are many checklists, sir. First is a WHO checklist, and the second is SURPASS checklist. Surgical patients safety factors. But sir, I personally believe before we go to the fancy checklist, we need to educate our healthcare providers. And actually, sir, we start with the top-down approach: consultants, and then senior residents, and then junior residents, and actually. The main stakeholders, in my opinion, they are the nursing staff. You may agree or not that most of the time spent with the patient is by the nursing staff. So checklists are there, sir. Definitely, like WHO checklist. WHO checklist, sir, is basically is meant for mainly in the operating room, before induction and before NCM and before the patient leaves the operating room. It mainly encompasses all that horizon while the patient is inside the operating room. Actually, sir, the safety starts right from the clinic of the clinician. When the patient visits the clinic of the clinician, the safety measures need to be adapted. In the case of preoperative care and then followed by intraoperative and then postoperative care. And the whole scenario is encompassed by the one term that is called these days that perioperative care. So in my opinion, in preoperative care, we should emphasize on detailed history. Actually, sir, I would conclude in one line: go back to the basics. Actually, sir, we have left the basic, and we have done like sir said, like electronic medical records and like EMS system and EMR system, everything. It looks very fancy. It fantasizes someone. We are like advancing in every field, but we have no money with us. So we will have to go back to the basics. We will need to take the detailed history and examine the patient and then assess the comorbids and do a detailed and good pre-anesthesia assessment before the patient is subjected to surgery. And likewise, while the patient is in the ward the night before the surgery, I personally believe no doctor goes to the patient to document the things like which side is to be operated upon, whether it is right side or left side, where the stoma is supposed to be formed. This is done by nursing staff. Right? And the consent form is put in front of the patient. Please just sign kar dein. What is written in that consent form? Neither the staff nor the patient and nor the tenders don't know anything. So, sir, in my opinion, these checklists, they are very good. But after once we have done our homework, we have taught our basic stakeholders in the wards, in the hospitals, in the OPDs, and then, sir, in the operating room, mainly WHO checklist, definitely, if it is emphasized in true letter and spirit, it can avoid so many